Immunodeficiency diseases. As we all know, the main purpose of the immune response or the immunity is to protect our body against different kinds of infection caused by different bacteria, viruses, not only the organism but also against the components that are produced by these organisms. So the main function is to fight against the diseases and protect our body against the different types of diseases. Sometimes it can so happen that the immune response can go or it can cause autoimmune diseases and hypersensitivity reaction. So here in this topic we will be studying about the different kinds of immunodeficiency diseases. So the term immunodeficiency, deficiency is nothing but the disorders in development of an immune response. So the patient usually have this kind of the function that they are not able to mount an immune response towards the different kinds of organisms. So this can lead to variety of recurrent pyogenic infections leading to even malignancies. So here in this particular topic we'll be dealing about the different immunodeficiency diseases that can occur in different kinds of patients. So here the immunodeficiency disease is nothing but the impaired defense mechanism that can arise either due to humoral immune response or the cellular immune response. So that means it can include both the type of immune responses. Apart from that, it can also be brought about to the non-innate or the innate immune responses such as the phagocytosis or the other complement systems that are usually enhancing the immune response. So not only because there is a defect in the humoral or the cellular immune response, there is also a defect in the innate immune response which is involving the phagocytosis and the complement system. So these all can ultimately lead to the deficiency diseases which can take place in a patient who is more prone to recurrent pyogenic infections as well as the infections from the different types of microorganisms. Now these immunodeficiency diseases can be broadly classified into two major types. One is primary immune deficiency disease and the secondary immune deficiency disease. In the primary immune deficiency diseases, here there is an abnormality in the development of an immunity in that person or immune response in a person due to variety of environmental factors or the genetic factors. The immune system is usually not produced properly in this particular patient. So that are the diseases which are associated with the abnormality in the development of an immune system in a patient are called as a primary immunodeficiency disease. And coming to the secondary immunodeficiency disease, these are usually caused by the different microorganism or the diseases or the drugs or any other environmental factor that usually causes or interferes with the normal immune response and will not allow the immune response to be produced properly in the patient. So these are all included under the secondary immunodeficiency disease. So primary immunodeficiency disease only involving the abnormality in the development of an immune system in a particular patient. So you can broadly classify into two types, primary and secondary. Primary again involving the B cell immunity, that is the humoral immunity or the cellular immunity which is usually mediated by the T cells, or combined both humoral and the cellular mediated immunity can be involved in development of this immunodeficiency disease, that is the primary immunodeficiency disease. So there are variety of diseases that are associated, one with the B cell response and some with the T cell response and some involving both the immune responses, that is the cellular as well as the humoral immune response. So let us see in detail about each of the disease of primary immunodeficiency involving the humoral immune response. So humoral immune response is nothing but the response mediated by the B cells. B cells are the one that usually produces the antibodies. So when there is an antigenic challenge to the human body, the cells that are produced in response to the antigens are the antibodies via the B cells. So B cells get activated to produce an effector immune response where they produce the plasma cells, and these plasma cells in turn produces the antibody which goes and interacts with the antigen. Antibody does not eliminate the antigen in its own way. It activates the other components of the immune system, and ultimately the antigen can be eliminated from the body. So the immunity which is mediated by the B cell is called as the humoral immunity. Now when there is a defect in the development of humoral response, it can lead to variety of immunodeficiency diseases. So first thing that we'll be dealing over here is the X-linked A-gamma globulinemia. A-gamma globulinemia means there is a decrease in the production of IgG or the immunoglobulins, and it is X-linked. X-linked means usually takes place in the male child, occurring in the infants. So it was first discovered by Bruton in 1952, also called as Bruton A-gamma globulinemia, and seen in the male infants. So usually in the case of infants, the infants develops its own immune system after the 6 months. So before 6 months, it is the maternal immunoglobulins that can transfer the placenta and provide the fetus protection against different kinds of infections. So in this case of patient, the infant is not able to develop its own humoral immune response. So for first 6 months, it gets protected from the maternal antibodies, but after which it will be more prone to different types of infections, and leading to various types of pyogenic infections or the infections with the different kinds of bacteria. Here the child responds normally towards the viral infections, but there is a problem when the child is given a live vaccines with the polio in order to protect from the polio or the encephalitis. So they can develop an immune response, and hence it is said that the people or the patient with immunodeficiency disease or the child with an immunodeficiency disease should not be given a live vaccine. So X-linked means it is usually seen, it is mostly seen in the male, and it is A-gamma globulinemia, decrease in the production of immunoglobulins. And here all the type of immunoglobulins are depleted. Now, as we all know, there are different classes of immunoglobulins, and in the case of A-gamma globulinemia, you can see a decreased production of all the classes of antibodies or the immunoglobulins. And apart from that, there is an atrophy in the tonsils and the adenoids, where usually mounting these areas are the one that mounts an immune response towards the respiratory infection. So decrease in the production of antibodies makes this child more prone to respiratory types of infections. Here you can see a decrease in the production of the plasma cells and the germinal center. So it is in the germinal center where there is a clonal selection taking place to produce the antibody against the antigen. So here there is complete depletion of the plasma cells which are involved in the production of antibodies, and hence no antibodies are produced, and decrease in the germinal center, there is no clonal selection taking place over there. Ultimately, the B cells are produced in less number and inhibiting the production of antibodies. Here there is complete damage to the humoral immune response, but the cell-mediated immunity is normal in these kinds of patients. So there is no damage to the cell-mediated immunity, and hence they can this can be very well seen with the help of allograft rejection. So allograft rejections are usually are mediated by the cell-mediated immunity. So when there is an allograft rejection taking place in this patient, you can see a normal cell-mediated immune response, and apart from which these kind of infants are more prone to arthritis, hemolytic anemia, and atopic manifestation, which are all related to the immunoglobulin diseases, that is IgE, which are nothing but the hypersensitivity or the autoimmune disorders. Now, how do you treat this particular disease? As there is a decrease in the production of immunoglobulins and no immunoglobulins are produced by these infants, you can treat them by giving the immunoglobulin injection. So it is usually given with the type of the patient that usually responds towards this immunoglobulin, the weight, the kg weight of the body. So it is prescribed that 300 mg per kg weight of the baby is usually given as an injection, and usually given in 3 doses, and later on it is changed to 100 mg per kg weight of the body as the child is growing up. So decrease in the concentration of the amount of immunoglobulin can take place once the child is able to mount an immune response on his own with the help of cell mediated immunity. Now, because these injections usually have traces amount of IgA and IgM, you have to go about with the whole plasma fusion. So whole plasma fusion is nothing but collecting the plasma, having all the type of immunoglobulins aseptically, and then giving it to the patients who are usually lacking this type of antibodies. So this is X-linked A-gamma globulinemia, also called as Bruton A-gamma globulinemia, usually seen in the male infants. Next is the transient hypogammaglobulinemia of infancy. Here the term transient is included because it is not complete damage to the humoral immune response. It is only transient. So by second month, the baby starts producing its own antibody. But here in the case of this patient, there is a transient delay in the production of immunoglobulin molecules. So abnormal delay in the IgG synthesis leads to transient hypogammaglobulinemia, and before this the maternal IgG antibodies usually protect the baby from the different kinds of infection. So due to this transient agammaglobulinemia, the child is more prone to recurrent infections with the respiratory infections or the otitis media involving the ear infections or the other systemic infections. Now here there is a spontaneous recovery because there is no damage to the humoral immune response as such in this particular type of infection. So by 18 months the baby is able to mount his own immune response or the humoral immune response, and there is a synthesis of immunoglobulin molecules in the infant. So that is usually periodic, you can say a temporary type of defect that can be seen in the infants. So there is a spontaneous recovery to this particular type of disease. Next is it does not involve only male or the female, it can be seen in both the sexes, both male and female, and the treatment is again here you can go with the gamma globulinemia, but it is usually less prescribed because due to this injection there is a possibility that the development of the human immune response will not take place in the infants due to the negative feedback inhibition. Next type of humoral defect is the common variable immunodeficiency, also called as a late onset hypogammaglobulinemia. Again, decrease in the production of immunoglobulins, usually seen in the patients with the ages of 15 to 35 years. So it is again a temporary one, and usually takes place in very few patients who are not able to mount an immune response by producing its own antibodies. So because of this, the patients are more prone to recurrent pyogenic infections with the staphylococcus or the streptococcus, and also with the autoimmune diseases. Next is you can see malabsorption, less absorption in the intestines, and giardiasis, that is the recurrent infection with the organism which is a giardia that causes the intestinal infection. The IgA antibodies that can be seen in the patient is very less in amount, and it is less than 300 mg per 100 ml. So not only it includes IgG antibody, but the amount of other immunoglobulins is also less in this kind of patients. There are defective B cells, that is the B cells are not able to produce the antibodies in much amount to go and interact with the infections, and here it also involves the cellular mediated immunity, where you can see an increased T suppressor cells and a decreased TH cells. So the main purpose of the TH cell is to produce the cytokines to activate the B cells. So here in the case of this common variable immunodeficiency disease, there is a defective B cell response because of the lack of interaction between the cytokines and the production of the B cells. Again here the treatment is given where the gamma globulins can be given intramuscularly or intravenously. Next is the selective immunoglobulin deficiency. Now the term selective immunoglobulin indicates that there is a selective decrease in a particular type of immunoglobulin classes. In other deficiency you could see there is a complete or a drastic decrease in the immunoglobulin, different immunoglobulin classes. But here in the case of this patient there is a selectively decrease in the immunoglobulin classes. So we have got different immunoglobulin classes: IgA, IgM, IgD, IgG and Ig, each involved in a specific kind of reaction. Here in the case of this patient there is a selective decrease in either IgG, IgA or IgM. All these are involved in interacting with the different kinds of pathogenic bacteria and protects our body against the different types of diseases. So here this specific disease is also called as a dysgamma-globulinemias, and the most important immunoglobulin that protects our body against the different types of diseases is the IgA. IgA is also called as a secretory antibody because it has the ability to cross different barriers in the respiratory system or the intestinal system to go and interact with the antigen. So decrease in the IgA can lead to different types of respiratory infection or the intestinal infections. Also this IgA is involved to prevent steria. Steria is nothing but the complete loss of the fat from the body. So here there is inhibition of the fat absorption in the body. So styria is the misfunctioning of the fat metabolism in the body. Ultimately loss of fat can be seen in these patients. So due to the decrease in the IgA, it can lead to styria, and also atopic disorders which are involved with the hypersensitivity reactions, and the specific IgM antibody decrease can lead to septicemia. Recurrent pyogenic infection can lead to septicemia. IgM is the one that is pentameric in nature and have the ability to interact with the pyogenic bacteria. When there is a decrease in the IgM antibody, it can lead to septicemia. IgG is again the prominent type of immunoglobulin. The first to be produced against the different types of bacterial infections. So here, due to the loss or due to the decrease in the production of IgG, there is a chronic progressive bronchiectasis that is involving the pulmonary infections. So here the airways are completely destroyed in the case of IgG antibodies. Now here, next coming to the immunodeficiency with the hyper IgM. IgM is again a very important type of immunoglobulin molecule, and in this case of patients you can see an excessive production of IgM antibody, whereas the production of other immunoglobulins will be normal, and this is usually linked with X-linked and autosomal recessive disorder. S-linked again involving the male patients, and autosomal recessive means the recessive genes are present on the same chromosome, and they are the one that are involved in the disease causation, and they can be inherited. So it is usually inherited from generation to generation, and usually involving the male patient. Here, due to the hyper IgM antibody production, you can see an enhanced susceptibility to different kinds of infections, leading to thrombocytopenia, neutropenia, hemolytic anemia, and renal lesion. So there is an infiltration of this IgM antibody that causes most of the disastrous diseases or deleterious diseases inside the body. So due to the malignant infiltration, it can lead to renal lesions and renal damage too, and ultimately this IgM antibody, due to its enhanced protection, can also cause neonatal congenital rubella. Next is the transcobalamin 2 deficiency. Transcobalamin 2 deficiency is an autosomal recessive trait, again inherited from generation to generation, where the recessive genes are usually carried from the parent to the children. And here in this case, in case of this patient, there is a metabolic defect in the uptake of vitamin B12. Vitamin B12 is very important for the production of the hematobiosis or for the production of the RBCs. Now, when there is no proper absorption of vitamin B12 in the intestine, there is a possibility that there is a decrease in the production of RBCs, leading to anemia. So the metabolic function to uptake the vitamin B12 is lost in the case of these patients. So this is called as transcobalamin 2 deficiency. Another characteristic feature associated with this disease is the megaloblastic anemia. Megaloblastic anemia is nothing but the RBCs in the case of these patients are larger and abnormal when compared to the normal patient, and here there is an intestinal villus atrophy, decrease in the function of the intestinal villus. So it is in the intestinal villus where you can see the normal flora providing this vitamin B12. Now when there is no proper uptake of this vitamin B12, there is a loss of the production of hematobiosis, decrease in the production of RBCs, leading to anemia. So there is a depleted function of the plasma cells and immunoglobulins, and also there is a defective phagocytosis. Now this type of disease is usually treated with the injections of vitamin B12. So the patient can get relieved from the two important types of depletion, that is the plasma cells and the immunoglobulins. But this type of injection cannot restore back the phagocytic activity of the phagocytes. So next, coming to the cellular immunodeficiency. So as already discussed, the immunodeficiencies can be either mediated or is usually involves the humoral humoral branch or the cellular branch or both the branches, because it is an interaction of both the branches that helps to develop an immune response. So due to the humoral immune response, there are different types of immunodeficiencies that are related, whereas in coming to the cellular immunodeficiencies, the most prominent one is the thymic hypoplasia. Thymic hypoplasia, that is mostly involving the thymus, which are the one that produces the T cells or the cellular mediated immunity. So the T cells are the one that usually get produced in the thymus. They get mature in the thymus, and they become immunocompetent to mount an immune response. The T cell or the cellular immunity is very, very important to develop a whole immune response, because the cytokines that are released from the T cells activates the other cells of the immune system. So when there is a loss in the cellular immunity, you can see a depletion in the immune response towards any type of organism. So the first deficiency that is related to the cellular immunodeficiency is the Di-Georges syndrome, that is involving the thymus, and it is called as a thymic hypoplasia. Hypoplasia is nothing but decrease in the function or the incomplete production of that particular organ. So the thymus is the target over here, and incomplete thymus is usually formed. You can see this in the case of the mice, which are called as the nude mice, and in case of humans it is called as a Di-Georges syndrome. So there is a developmental defect involving the endodermal third and fourth pharyngeal pouches of the thymus, and which leads to aplasia, that is incomplete development of the thymus, and hypoplasia of the thymus. And it is not hereditary, it is not familial. It is usually caused due to intrauterine infections or due to the different environmental factors. So it cannot be taken as an hereditary disease, but it is due to certain types of abnormalities during the development of the infant. And the characteristic feature associated with this type of disease is a phallus tetralogy, that is a congenital heart anomalies. Heart and facial appearance can be seen in this case of thymic hypoplasia. And also the other characteristic feature is a neonatal tetany, which is the hypocalcemia. Excessive amount of calcium can be seen in this particular infants, which can be detected with the help of different serological tests. And these peoples are more prone to viral infection, fungal infections, bacterial infections, etc. The cellular immunity is completely lost because of the decrease or the hypoplasia of the thymus. You cannot see the thymus dependent area in the lymph node or the spleens. They are usually shows less amount of T cells, and the T cells are very important in mounting an immune response. So complete damage to the cellular immunity can be seen in these patients, and decreased hypersensitivity and graft rejections due to the cellular mediated immunity, and humoral immune branch is not very much affected. That is, a primary immune response is normal in the case of this patient, but the secondary immune response is usually lost because of the cellular mediated immunity. So the person cannot mount a secondary humoral response in this kind of patients. So both the responses are lost over here. That is the cellular mediated immunity and the secondary humoral immune response. And this can be treated with the help of thymus transplantation, and the patients can be restored back to its normal health with the help of the thymus transplantation. Next is a chronic mucocutaneous candidiasis. So there is an abnormal immune response that is directed towards this particular organism which is called as candida. Candida is a fungus, and it is usually causes candidiasis of the mucous skin and the nails. Also involving the endocrinopathies, that is destruction to the endocrine glands, mostly leading to hypothyroidism or the hyperthyroidism. And in this case of patient, as usual, the CMI is deficient, and you can see a delayed type of hypersensitivity absent in the case of this candidiasis patients, and there is a defective intracellular killing. Now, due to the involvement of cellular immediate immunity, the phagocyte also gets decreased in the case of these patients. Now, when there is a decrease in the phagocytosis, you cannot see the intracellular killing of this particular organism, and the treatment for this type of disease is a transfer factor. Transfer factor is nothing but transferring with the T cells. So transfer factor treatment therapy can be given along with the amphotericin B to treat different kinds of infections caused by bacteria and the viruses. Next type of cellular immunodeficiency is PNP, that is purine nucleoside phosphorylase deficiency. Now purines, as we all know, they are the nitrogenous compounds that are building blocks of the DNA molecule. Now the enzyme purine nucleoside phosphorylase is the one that converts the sequential degradation of purines to hypoxanthine and ultimately to the urea. So decrease in the you can say the uric acid level can help us to identify whether a patient is deficient in this PNP enzymes, and it is an autosomal recessive trait that get inherited from generation to generation. In this kind of patient, there is a decreased CMI, recurrent and chronic infections can be seen in the patients, and along with that, the characteristic feature associated with this is a hypoplastic anemia, pneumonia, and diarrhea and candidiasis. And the diagnosis is that is how to identify this disease is with the low serum uric acid. Next is a combined immunodeficiencies. So as we all know, to develop an immune response, the interaction of both the immune response is very essential, that is humoral as well as cellular immune response. So whenever there is an organism that is gaining an entry, the antibodies are produced. Along with this, the other important immune cells are gets activated. So in order to activate the T cells, we require the phagocytes, which usually process the antigen and presents the antigen to the TH cells or the TC cells, depending upon the MHC complex. Now once these TH cells get activated, they release the cytokines that in turn activates the other immune components or the immune competent cells, ultimately leading to the elimination of this antigen. But in the case of these immunodeficiency diseases, there is a combined loss or improper development of both the responses, both the humoral as well as the cellular immune response. So interaction of these is lost, as a result of which the person suffers from this combined immunodeficiency diseases. The first one that we'll be dealing here is the Nesloff's syndrome. It is a group of disorders involving the decrease in the CMI, and there is a variation in the immunoglobulins or the humoral immune response. It can be a normal immune response, or it can be a decreased production of the immune response, or it can be ultimately lost to the humoral immune response. So due to this association is lost and leading to Nesloff syndrome. So there is a varying degree of humoral immunity, but completely reduction in the cellular mediated immunity, and the patient suffers from recurrent fungal or viral or protozoal infections. And here the patient has an abundant plasma cell. That means humoral immunity is normal, but it is defective and it is not able to mount an immune response along with the cell mediated immunity. Even though the immunoglobulins or the plasma cell is normal, producing the antibody, but it is not able to mount the immune response because of the absence of the cellular mediated immunity. So leading to thymic, this can lead to thymic dysplasia. Abnormal productions can be seen in the case of these patients, and there is no clonal selection over here, ultimately leading to production of different kinds of T cells that can cause a damage to the organism as well as to the host own immune system, so leading to autoimmune anemia. And here you can see the normal level of IgG, because the plasma cells are normal in number, but there is a decrease in the CMI, and the treatment is usually done with the help of transplantation, that is histocompatibility, bone marrow transplantation, or the thymus transplantation. And to treat the different infections caused by the organism, you can go with the antimicrobial therapy. Next is ataxia-telangiectasis. Ataxia is nothing but the loss of the normal control over the bodily movement. So usually caused in the immunodeficiency disease, and telangiectasis is nothing but the formation that there is a dilation of the capillaries that usually carries the RBCs. So it can involve any organ of the body, and here you can see the characteristic feature of this telangiectasis is the formation of a spider-like capillaries that can be seen in the different organs. So that is what is called as ataxia-telangiectasis. So it is an autosomal recessive disorder carried from or inherited in generations. It can involve cerebellar ataxia, that is involving the brain, or a telangiectasis, that is the dilation of the blood capillaries of the different types of the organs inside the body, and it can also lead to ovarian dysgenesis and chromosomal abnormalities. And the signs of these ataxia telangiectasis is ataxia, that is there is a no normal or voluntarily body movements cannot be seen in this, and choreoagitoid movements in the infants, that is the loss of normal body movements is usually lost in the case of this infants due to the ataxia. Next is telangiectasia. It involves either the face or the conjunctiva, usually in the patients between 4 to 6 years, and the death occurs in the patient due to sinopulmonary infections. And here in the case of this patient, the patient lacked the serum and there is a decreased production of IgA antibodies, leading to progressive neurological and grafts rejections. And coming to the treatment aspect, you can treat them with the help of T factor therapy, that is the transfer of with the T cells or the fetal thymus transplants. Wiskott-Aldrich syndrome, again cellular immunodeficiency, which is an X-linked disease, here involving the male patients who usually express the characteristic feature of eczema and thrombocytopenia purpura. The male usually dies in the first decade of his life, and the death is due to infection or the hemorrhage or lymphoreticular malignancies. The cellular humoral immune response is normal, that is the production of IgM is very low, whereas the production of other classes of immunoglobulin is normal in nature. So there is a complete deterioration of the CMI, that is a cellular mediated immunity, and the serum IgM is low when compared to the other antibodies. And here in the case of this patient, you will not see the isohemagglutinin. Isohemagglutinins are nothing but the antibodies that are present along with the antigens on the RBCs. That is, as we have seen, the person with the A blood group, they have antigen A, but the isohemagglutinin that is present is the B antibody. So here in the case of this patient, there is absence of the isohemagglutinin, and the humoral defect is usually seen because they are not able to mount an immune response towards the polysaccharide antigen. Polysaccharide antigens are nothing but the organism which have a capsule around themselves that helps to them to escape the phagocytosis. So humoral immune response is completely lost. Because of this, there are many chances that the person can be infected with a variety of pyogenic infections, and the treatment is very well done with the help of bone marrow transplantation or the transfer factor therapy. Next is the immunodeficiency with thymoma. Thymoma is nothing but the cancer of the thymus. That is not a malignant cancer, but it is a benign cancer that can be seen in this kind of patients. So mostly seen in the adults, and it is the characteristic feature of this thymoma is it is a benign thymic tumor which results in impaired cellular mediated immunity, and the humoral response that is associated with this is a gamma globulinemia. Because there is a decreased CMI that is seen in this kind of patient, there is a decreased production of the immunoglobulin that is associated with the thymoma, and the characteristic feature of this is aplastic anemia. Here in the case of thymoma, there are chances that the antibodies are produced against the thymic cells and can damage the thymus in turn. Next is the immunodeficiency with the short-limbed dwarfism. The characteristic feature in this case of patient is the short-limbed dwarfism, and ectodermal dysplasia, thymic defects is seen, and they are highly susceptible or enhanced susceptibility to different kinds of infections, and it is an autosomal recessive disorder. Next is episodic lymphopenia with lymphocytotoxin. So this type of disorder or the disease is episodic, but here you can see a profound decrease in the cellular mediated immunity. The T cell depression is usually seen due to the damage to the T cells by the complement dependent lymphocytotoxins. Lymphocytotoxins are nothing but the antibodies. So in the case of these patients, the antibodies are mounted against the self T cells, ultimately causing the decrease in the T cell affecting the cellular mediated immunity. So it is a T cell depression is due to the complement mediated lysis of the T cells along with the lymphocytotoxin. That is, the antibodies along with the complement damages the T T cells, thereby decreasing the cellular mediated immunity. So the toxin over here, the lymphotoxin, is nothing but the anti-lymphocyte antibody. And the anti-lymphocyte, the lymphocyte that are involved over here are the T cells. So anti-lymphocyte antibodies goes and interacts with the complement, that is enhances the complement system, ultimately targets the own T cells, leading to the decrease in the cellular mediated immunity. Here there is no immunological memory that is related to this type of cellular immunodeficiency. Next, coming to the most fatal one is called as a severe combined immunodeficiency disease. So it is combining both the responses, humoral as well as the cell mediated. So in the other diseases you have seen that there is a decrease in the cellular mediated immune response, but there is a variation in the humoral immune response. The humoral immune response can be normal or sometimes can be depleted. But here in the case of this severe combined immunodeficiencies, both the immune response are lost, and hence these type of patients are recurrent to most of the type of infections with the bacteria, viral and the protozoa. So it is an autosomal recessive mode can be seen in the patients, and the primary defect is that is involved over here is the involvement of the precursors of immunocompetent cells. Precursors of the immunocompetent cells are nothing but the naive cells. So from the naive cells, after the antigenic challenge, the naive cell becomes an immunocompetent cells. Now these immunocompetent cells, once they are developed, they are involved in the immune response to produce the effector cells and the memory cells. So here the damage is at the precursors of the immunocompetent cell, thereby not allowing any of the response to take place, either the cellular immune response or the humoral immune response. As we know, the effector cells of the humoral immune response are the plasma cells. So plasma cells gives rise to antibodies, whereas the effector cells of the T cell mediated immunity are the Th cells or the Tc cells. Th cell releases the cytokines, activates the other cells of the immune system. T cells are the one that are targeted against the tumor cells or the virus infected cells. So in order to develop any type of response, whether it is a humoral response or the cellular response, the immunocompetent cells are very, very important. So here the damage is direct to the immunocompetent cell, thereby not allowing any type of response to develop. So it was first described or seen in the Swiss laboratory, where the Swiss co-workers has carried out this type of have discovered a severe combined immunodeficiency disease, mostly involving the immunocompetent cells. Next, the severe form of this type of disease is a reticular dysgenesis of D-val. So here the target is a multi-stem cell, the multipotent hematopoietic stem cell. So hematopoiesis is nothing but the generation of different kinds of cells, whether the RBCs or the lymphocytes or the leukocytes. So it is during the hematopoiesis, the pluripotent cell, that is a multi or the hematopoietic stem cell usually carries two types of lineages or migrates to two types of lineages, that is a lymphoid lineage and a myeloid lineage. So when it enters the lymphoid lineages, it can synthesize B cell, T cells and a natural killer cell. But once it enters the myeloid lineages, it is able to produce the neutrophils, basophils, eosinophils, platelets, macrophages or the monocytes, etc. So when there is a loss to this hematopoietic stem cell, it is not able to progress either to the myeloid lineages or the lymphoid lineages, thereby decrease in the production of these cells is usually seen. So the characteristic feature is the lymphopenia or the neutropenia. You can see a damage or the platelet aplasia, etc. So complete loss to the both the immune responses seen in the case of this severe combined immunodeficiency disease, that is a reticular dysgenesis of the D-val. And next is the adenosine deaminase deficiency. It is the first enzyme deficiency that can be seen, and this enzyme is involved in conversion of adenosine to the inosine. So there is a metabolic pathway by which the adenosine is converted to the inosine. So complete absence of this can lead to mild abnormalities leading to decrease in the production of the B and T cell. That is abnormal production of the B and T cells can be seen, and along with that there is a decrease or abnormal production of the chondrocytes. Chondrocytes are nothing but the cells that are seen in the bone, and they are the one that releases the cartilage and are present in the bone marrow. So there is a decrease in the production of the chondrocytes along with the B and the T cells. So this is about the combined immunodeficiency diseases of both humoral branch and the cellular immune response. Now apart from these branches, as already discussed, it is not only the humoral branch or the cellular immune response that helps to eliminate the infection, but it works in collaboration with the innate immune responses such as the complement system and the phagocytosis. These two systems helps in enhancing the immune response to fight against the different types of diseases. So any deficiency in complement or the phagocytic cells can lead to the deficiency diseases or the immunodeficiency diseases. So let us see about the complement. Complement, as we all know, they are the series of proteins that are inactive in the serum, and once there is an antigenic challenge due to variety of factors, they get activated. They work in classical or the lectin pathway to get activated to ultimately form a membrane attack complex, and this membrane attack complex can cause the lysis of the bacteria in combination with the antibody. So complement is nothing but it complements the activity of the antibody to cause the lysis of the bacteria. So any deficiency in the complement protein can inhibit the lysis of the bacteria along with the antibody. So it is a genetic deficiency, and it is the one which is an autosomal recessive trait deficiency and causing systemic lupus erythematosus, that is a systemic infections. And next is the decrease in the production of C3 complement protein leads to recurrent pyogenic infection, and decrease in C6, C7, C8 can lead to serial infection, that is sexually transmitted diseases. Next is the complement inhibitor deficiency, which mostly involves the C1 inhibitors, and here you can see the characteristic feature associated with this C1 inhibitor is the hereditary angioneuritic edema, and it is an autosomal dominant trait and can be treated with the help of the androgens, aminocaproic acid and tranexamic acid. And apart from that, you can also go about with the plasma infusion, which will contain the complement proteins that can help to relieve the patient from this type of deficiency. And the deficiency in C3b leads to pyogenic lesions caused by different types of pyogenic bacteria such as Staphylococcus, Streptococcus, Clostridium, etc. Next is the disorder in the phagocytosis. Now we should know what is phagocytosis. Phagocytosis is nothing but the engulfment of the antigenic bacteria or the viruses, usually the DNAs of the organism, usually involving the viral infections. So the phagocytosis is brought about by the macrophages, which ultimately degrades the organism by its intracellular killing and releasing the component and presenting it to the T cells. So cellular mediated immunity can be active only after it has been processed and presented along with the MHC molecule, which are seen on the phagocytes. So any disorders or any defect in the phagocytosis can lead to different types of immunodeficiency disorder, usually affecting the cellular immune response. Now these disorders of the phagocytosis can either be due to intrinsic or the extrinsic factors. The intrinsic factor, that is involving the phagocytic cell, that is during the phagocytosis there is a deficiency in the enzyme. Now in order to bring out phagocytosis, the phagocytic cells have lysosome inside it. So the lysosome is the one that degrades the antigenic molecule or the organism inside. Along with that, it usually carries out different mechanism by which it can degrade the organism that has been engulfed by the phagocyte. So coming to the extrinsic factors that causes the defects in the phagocytosis is the opsonic antibody, complement, drugs or anti-neutrophil antibody. Any decrease in the type of opsonic antibodies or the complement or anti-neutrophil antibody can cause a disturbance to the phagocytic activity of the phagocyte. So it can be either intrinsic or the extrinsic that can cause damage to the phagocytic cell and cause the immunodeficiency diseases. The first disease associated with this is a chronic granulomatous disease. Granuloma is nothing but due to the defective in the intracellular killing, the cells get hidden and protected and can multiply inside that phagocytic cell, causing a granuloma in that particular area. Usually this type of granuloma is seen on the skin and the lymph nodes. So it is the inability of the phagocyte to kill and instead protect the organism inside it against variety of antibiotic or the other component or the antibodies, thereby forming a granuloma. So here in the case of this phagocytic defect, the patient can be very well produce this type of granuloma that can be seen on the skin and the lymph nodes. And apart from that, you can also see the characteristic feature associated with this is hepatosplenomegaly, that is the enlargement of the spleen glands and the infiltration of the lungs. More amount of organisms are usually embedded inside the phagocyte, so they try to attract different cells of the immune system to that particular area. As a result of it, infiltration can be seen in the lungs when there is a respiratory infection, and granulomatous septic osteomyelitis also can involve the bones. And here the bacteria that is mostly involved or dealt with is the catalase positive organism and the coliform. So catalase positive organisms are usually engulfed by the phagocyte, and the inability of the phagocyte to kill protects this organism inside it against the antibiotics or the antibodies. Now due to this, what happens is there is a delay in the release of the granules that are present in the phagocytic cells. Now the granule contains the anti-lytic enzymes to cause the lysis of the bacteria. Now when there is a delay in the production of the lysis lytic enzymes by the phagocytic cell, the organism is not killed. As a result of which, a granuloma is seen. So there is a delayed granule rupture, and that can be seen. Apart from that, the other metabolisms that usually kills the organisms are lost. That is the diminished hydrogen peroxide that is produced, that can also decrease the phagocytic activity of the phagocyte, and you have the glucose HMB pathway that is also decreased in this particular case. So in order to identify this decrease in the phagocytic activity, you can go with a nitrobrew tetrazolium test. So here in this particular test, in the case of active phagocytic cell, it gives a positive test. But here in the case of this particular deficiency in the phagocytic activity, it usually gives a negative test. And it is mostly seen in the boys and said to be S-linked and can be autosomal recessive, mostly in the case of girls. Next is the myeloperoxidase deficiency, again related to the neutrophils or the phagocytic cells. Phagocytic cells brings about the lysis of the organism by the release of this myeloperoxidase. When there is no myeloperoxidase produced, it can lead to different types of infection. Mostly the type of infection that the patient is prone to is the Candida albicans infection. Next is celiac Higashioka syndrome. It is a genetic disorder. The characteristic feature of this is a decreased pigmentation that can be seen on the eye, skin and the other parts of the body. And the feature that is related with this is a giant peroxidase positive inclusion bodies, again due to the loss of phagocytic activity and killing of the intracellular bacteria. And apart from that, you can also see an anti-phagocytic activity. So that is the antibodies that are produced against this phagocyte can also cause clumping and cause the granuloma. And most of the infections that are seen in this kind of patients are the pyogenic infections. Next type of phagocytic disorder is leukocyte G6PD deficiency, glucose 6 phosphate dehydrogenase deficiency. It is a rare disease, and there is a deficiency of this glucose 6 phosphate dehydrogenase involving diminished bacterial activity. That is the bacteria are not easily killed, and leading to chronic granulomatous diseases. And here in this kind of patient, the NBT test is normal. Next is a Job syndrome associated with the staphylococcal disease. It is called as a cold staphylococcal abscesses that can be seen in the patients, and it usually initiates at 37 degrees centigrade, and it is seen only at chilling temperature. So it is called as a multiple large cold staphylococcus abscesses can be seen in the patients, and it is a characteristic feature of it, only seen on the skin, and leads to atopic eczema, chronic nasal discharge and otitis media. bacteria involving the respiratory system or the ear infections. And here you can see abnormal production of IgA antibody which is leading to hypersensitivity reaction, and phagocytic function is completely lost. Next is a Tuftson's deficiency. Tuftson's deficiency is nothing but a leukokinine. It was discovered in Tufts University, and it is a tetrapeptide consisting of tyrosine, lysine, proline and arginine. Threonine, lysine, proline and arginine. So decrease in the production of this Tuftsone decreases phagocytic activity. That is, there is an interaction between this leukokinine and the phagocytic activity. So decreased production of this leukokinine causes decreased phagocytic activity, leading to local and systemic infections. Next is a lazy leukocyte syndrome. Here lazy leukocyte syndrome is nothing but there is a normal production of the phagocytic cell, but the movement of the phagocytic cell towards the inflammatory response is very slow because of the loss of chemotaxis. So the normal production is there, but they are not able to move to that particular area. Chemotaxis is a phenomena where due to the inflammatory response, certain chemical mediators are released which attracts the phagocytes to that particular area where there is an inflammatory response is going on. Now due to the lack of these chemotaxis, the neutrophils are not able to move. So hence there is a low mobility of these neutrophils or the phagocytic cells towards that particular inflammatory response. So that is what is called as a lazy leukocyte syndrome. So there is a peripheral neutropenia. Peripheral neutropenia means there is a decreased production of production or seen less number of neutrophils at the place where there is an inflammatory response, but the phagocytic cells that are produced are in the normal mode. So leading to variety of bacterial infections, recurrent stomatitis involving the inflammatory response of the mouth, gingivitis, that is the gums, and also leading to the otitis, that is ear infections. Next is the hyper IgE syndrome, which is ultimately causing a decrease in the phagocytic activity and leading to recurrent bacterial infection. So it is an early onset eczema. IgE is the antibody that is the one that usually mediates the hypersensitivity reaction. So early onset eczema is seen along with abscesses and pneumonia, and secondary infections are due to eczema, and the organisms that are mostly involved over here are the Staphylococcus aureus and Streptococcus pyogenes, which are pyogenic in nature. And in the case of this patient, you can see the serum level increasing up to 10 times the normal IgE that can be seen in a normal individual. Next is the actin binding deficiency. Now this actin binding is very important to carry out the normal function of the lymphoreticular system. Now when there is a decrease in the actin binding deficiency, it can lead to slow mobility, that is a lazy leukocyte deficiency diseases, and thereby the persons are more prone to different types of infection due to neutropenia or decrease in the production of the phagocytes. Next is the Schwarzman's disease. Here again there is a decreased mobility, pancreatic malfunction and bone abnormality that can be seen in this patient due to the various immune response that are lost during this immunodeficiency disease. Next, coming to the secondary immunodeficiency disease. So we have classified the immunodeficiency diseases as primary and secondary. Primary involving the abnormality in the development of an immune system. Due to an abnormality, there is an immune system that is completely lost. Now it's coming to the secondary immunodeficiency. Here the other factor interferes with the normal immune response and will not allow the proper functioning of the immune response to take place. So the factors can be different that are the one that leads to secondary immunodeficiency diseases. One is a malnutrition, second is the malignancies, that is the tumors, or infection with the viruses and the other pyogenic bacteria. There can be metabolic disorders due to variety of environmental factors, diet, nutrition, etc. and cytotoxic drugs. These drugs usually goes and causes the lysis of the cells that are usually involved in proper functioning of the body. So when it is lost, there is leading to the secondary immunodeficiency disease. And the most prominent one is the AIDS, acquired immunodeficiency disease, which is a secondary immunodeficiency disease. So it is so called because the virus targets the immune cells, that is mostly the CD4 cells. So here in this slide you can see The HIV is the one that goes and interacts with the CD4 receptors. So CD4 receptors are the one that are present on the Th cells. Th cell are the one that releases the cytokines and activates the other cells of the immune system. So when there is a loss or decrease in the CD4 receptors or the Th cell, there is a loss in the cellular mediated immunity, ultimately affecting the whole immune response. So that's why it is called as a secondary immunodeficiency disease. And here coming to the secondary immunodeficiency disease that can brought about by the humoral or the cellular mediated. So coming to the humoral cellular secondary immunodeficiency disease, here you can see a B cell depletion and the increased immunocatabolism in the case of nephrotic syndrome, and the serum proteins involving the exfoliating skin disease and abnormal IgE leading to multiple myeloma. So here they can target the B cell at any stages. So here they can target the complete decrease in the B cell production, that is complete the B cell depletion can be seen, or there is an increased immunocatabolism. So due to this it can lead to nephrotic syndrome and targeting the serum proteins leading to exfoliating skin diseases and abnormal IgG production leading to multiple myeloma. Next, coming to cell mediated immunity, that is a secondary diseases associated with the cell mediated immunity. Here there is a depressed or lymphoreticular malignancies which is can be seen in the Hodgkin's disease or Hodgkin's lymphoma, lymphorias and leprotomous leprosy. So infiltration of these cells, usually in the case of leprotomous leprosy, the one blocking the gland to carry out its normal function leading to the leprosy, and sometimes it can also lead to measles. So this is about the immunodeficiency diseases.